Good afternoon, everyone, and welcome to Kenjan's DEI Spotlight. Every month, we deliver a focused presentation that is relevant to national trends as well as the National Diversity Calendar. Last month, if you were able to join us this past June in celebration of Pride, we looked at gender diversity with Cy Burnaby, the Executive Director of Gender Justice Nevada, and learned how to respond when someone trusts you enough to come out to you. And you don't say, I already knew. We also learned about rainbow capitalism with Jay Booth, who is the manager at the center. And we talked about how police brutality was the last straw for Stonewall Inn patrons who were also exploited by the establishment, which is the definition of rainbow capitalism. And that is when the Pride movement began. In July, we focused on Minority Mental Health Awareness Month and examined the effects of police brutality on mental health with Captain Hank of the Las Vegas Metro Police Department and Deputy Chief Michael Blow with Henderson, who revealed the work that the departments are putting in to ferret out the bad apples. These presentations may be consumed on demand. Visit our YouTube channel for the complete replay and look for the link in the comments. Today's presentation will focus on health disparities. And I'm really excited to talk about this. It was August 2020 when Governor Steve Sisolak made a declaration. He announced racism as a public health crisis in Nevada on August 5th, 2020. With this month marking the 2-year anniversary for this declaration, I wanted to take an opportunity to amplify this particular message. Today's conversation will feature Tina Dortch, MPA, and Dr. Melva Thompson-Robinson. This really will be a conversation that you don't want to miss. If this is your first presentation, allow me to introduce myself. My name is Kenadie Cobbin-Richardson, and I am a partner at Kenjan Consulting. We are a firm specializing in justice, equity, diversity, and inclusion, aka JEDI, using design thinking and innovation to solve complex problems, grant writing to fund promising solutions, and tourism and hospitality, providing experiences that add to the quality of our lives. Through our training, we are laser focused on actual behavioral change by building a groundswell of DEI champions and allies that are influential at every part of your organization. So our customized training allows us to, one, acquire the essential skills to have courageous conversations. Secondly, to really help you acknowledge and accept the history and context of America, of injustice in America, as well as 3, articulate the lived experiences of marginalized groups, and 4, act as an ally to accelerate where you live, work, and play. Again, I am a consultant for DEI consultant for multinational corporations and nonprofits. I've worked in youth development, workforce development, community development, healthcare, and financial services. I've been a nonprofit executive director for more than 20 years of 2 youth serving and community developed nonprofits. And my passion truly is helping people embrace both themselves and society on their journey to allyship. And what is an ally? It's a person of one social identity group who provides actionable support to members of another group, typically a member of the dominant group, forming an alliance with marginalized individuals or groups that are being discriminated against or treated unjustly. And as we examine health, housing, education, and employment, health disparities really cross all of those domains. And what is health disparities? They are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. When we look at some of the categories, we look at mortality, life expectancy, the burden of disease, mental health, uninsured or underinsured, as well as lack of access to care. And when we talk about, these disparities, we've known about them since the early 2000s when nearly two decades ago, when the Surgeon General report published documented disparities in tobacco use and access to mental health care by race and ethnicity. And despite the recognition and documentation of disparities for decades and overall improvements in population health over time, many disparities have persisted and in most cases widened. And so when we look at what's happening, this problem is not getting better. In fact, it is getting worse. And these issues are compounded by economic stability. You don't have a job. A lot of times you don't have health care. If you have low income, or the neighborhood you live in does not allow you to have access to health care, literacy in your language could prevent you from getting good health care. Obviously, living in places where there's not an availability of fresh foods and fresh fruits and vegetables, and access to other healthy options, the community safety and social context, dealing with stress all the time, exposure to violence, police brutality, as well as the healthcare system itself with institutionalized injustice baked into the systems and processes. It is not a coincidence that Black children have a higher incidence in asthma based on the toxicity of the neighborhoods in which they live. When looking at mortality, Black Americans experience significantly shorter life expectancies than non-Hispanic white Americans, with higher mortality rates linked to relatively earlier mortality from diabetes, cancer, cardiovascular disease, homicide, and perinatal conditions. When you look at, so those are general broad statements, but when you look at the rates of infection and hospitalization and death due to COVID-19, you can see that Native Americans, Blacks and Hispanics have higher cases, whereas Asians and whites lower incidences and hospitalizations as well as death. When you look at people of color and the population density that we have, for example, in 2020, people of color represent 39% of the population. However, in 2050, it will be 52% of the population. So to have disparities continue to exist means that half of our population are experiencing greater death, morbidities, lack of health care, being underinsured. And that is a surefire way to tank the entire country, and we will no longer be competitive. And so all the pride that we have in being US, being an American, really will pale in comparison to other countries who don't have these kinds of disparities baked into their everyday existence. And so I'm so glad that I have two very good friends coming on today who are experts in this field, who will give us, really a way forward. Obviously, as we continue to talk about these things, it's like, what can we actually do about it? And today we have some people on who really will be able to give us some light at the end of that tunnel, hopefully. I met Tina Dortch a while ago when she was with Tesla. But Tina is a fantastic person that I have had the pleasure of getting to know over the last decade or so. She was born in Detroit, Michigan. She relocated to Nevada in 2006. She holds a Bachelor of Arts degree from Michigan State University in political science and public administration. And she also holds a Master of Public Administration degree from the Ohio State University in Urban Planning, Administration and Planning. I'm from Ohio, so I had to add the "the" if you don't know what that really means. Since 2018, Tina has been committed to advancing health equity, having accepted a position with the state's Department of Health and Human Services to manage its Office of Minority Health and Equity. Often working with external stakeholders, she develops system-changing initiatives and policies that work to reverse disproportionately experienced health outcomes across all health determining sectors. She promotes the equitable provision of healthcare resources, and she raises awareness around adopting culturally and linguistically sensitive principles. We also have a great friend, Dr. Melva Thompson-Robinson. She is a professor in social and behavioral health in the School of Public Health. She is currently the project director for the Southern Nevada Teen Pregnancy Prevention Project, which implements an evidence-based intervention with African-American youth ages 14 to 19 in African-American faith-based organizations. Among many things, she is a member of the U.S. Department of Health and Human Services Region 9 Health Equity Council. And her research specialties are health disparities, sexual health, including HIV, AIDS prevention, and teen pregnancy prevention, as well as African-American health. And so I would like to bring on both Tina Dortch and Dr. Melva Thompson-Robinson. Say hello.
Hello. Hi, everyone.
Hi, so let's get started. Tina, uh, I know that you are doing quite a bit of work in your current position. And so can you tell us all about the work of Nevada's Office of Minority Health and Equity, and also
Oh,
how inequity and social injustices produce the health consequences that we were talking about earlier?
absolutely. Thank you for this opportunity, Kenadie, and I'm very happy to be here with Dr. Thompson-Robinson. The Office of Minority Health and Equity has a very distinguished history. We began in 2005, and we are a network. We're part of a larger network of offices of minority health. One is usually found in most Department of Health and Human Services across the country. But in our case, the office was very dedicated to very disease focused activities and reversing those disparities through education and awareness. But in the more recent years, beginning when I took over the office in 2018, there was a shift. There was a change in the culture as opposed to being more disease specific. It's about systems change. And so our office has embraced that with that 2018 directive through some administrative and also legislative directives. So now our work is focused on activities that we can identify more easily measurable in more easily measurable way. For example, we are looking at ways to talk about health in our policies across all platforms. So no matter what sector you work in, Kenadie, be it transportation, be it someone who's actually doing workforce development, these we recognize as those determining factors and categories of health, correct? And my office helps point out how those individual entities and sectors can influence a community's wellness, not just health from a physical and mental perspective, but your wellness. We now recognize that health is defined more broadly. And so my office has been very instrumental in bringing to light those type of concepts. And when we do that in a way that is measurable and most notable through pilots, I am a huge proponent, Kennedy, of a pilot initiative. Pilots serve as proof of concepts. And when you have a proof of concept, at the end of that process, you have evidence and you have a small scenario where you've tested a theory. And so we work with universities to work out these pilots, and these pilots all fall under the umbrella of health and all policy. And we've got about 6 or 7 that have been completed, and we've got a new set of about 3 or 4 that are underway right now. Some of those in the past had talked about illegal dumping and how that can have not only an aesthetic impact on usually at risk communities, correct, but also have an aesthetic of impact. Some of our more current high-up policies are looking at things like maternal health and the role that doulas play. So we're timing this with our upcoming legislative session to have these recent high-up pilots to be completed and to have the outcomes ready to share with any legislator that might want to have that information. So that's a little bit in a very quick general overview.
Excellent. Thank you for that. Dr. Thompson Robinson, can you talk to us about what you do at UNLV and some of the things that you're working on?
So, yes, thank you, Kennedy, for having me on today. So, I am a faculty member at UNLV. I'm actually just coming back from sabbatical. So, I spent the last year looking at anti racism in clinical health settings, working with Denver Health and those initiatives. So, have written a document looking at, like what are the strategies that organizations need to be doing in order to really promote anti-racism and promote health equity for different organizations. So as you said, I've done a lot of work around health disparities and working with, for example, I spent a long time working with community-based organizations to build capacity around public health prevention and strategic management, because we were seeing that organizations were getting funded primarily from CDC, and as soon as the money went away, the organizations went away. But they were organizations that were working specifically in communities of color and specifically in communities most infected and affected by HIV. You mentioned I've done work in teen pregnancy prevention, also currently working on some efforts around maternal and child health. I am the former executive director of the Center for Health Disparities Research here on campus. Currently still the editor of the Journal of Health Disparities Research and Practice. So, teaching in that area, but also lecturing in our medical school and our dental school about these topics as well.
That's great. Thank you for that. So having both government and education in this conversation, I think, is a really great place to start. And my question to each of you is, whose responsibility is it to address health inequities health inequities in broad in health as well as society, and some of the other inequities that obviously are contributors of health inequities or disparities? Whose responsibility is it to get some of these solved, based on the fact that it hasn't been solved in the last 20 years? I don't know if we're passing the buck, but who can we hold accountable?
Tina, do you want to go first?
I don't mind at all. Thank you. And I'm certain that Dr. TR will agree with me that it's everyone's responsibility. But when I say that, I don't say it flippantly. I mean that we absolutely have to empower people, because one of the problems with health disparities is that it's a reflection of power imbalances. And the reason that individuals are experiencing these disparities is because they don't have the information that they need. So in order to be your own advocate, we have to make sure that that information is available, as you mentioned at the top of the call, in culturally and linguistically appropriate materials, things that are at a comprehension level that anybody can embrace and then put into use. There's a new initiative that I had just learned a phrase about, didn't know it existed, but we've been doing it, Dr. TR, is policy literacy. That if someone is not literate about policy, that it's very difficult to advocate for yourself. And so we also look at making sure that individuals are just on the same platform, at the same plane, in order to advocate for these changes. Because health disparities, by definition, are preventable, correct? Oftentimes, they're a manifestation of what we call wicked problems in the world: homelessness, undereducation, underemployment, things like that. These are problems that can be solved. And these problems have also at the apex and at the center, and as part of their common root causes and outcomes, a health disparity. If you're underemployed, you may not have the proper health care, and you may not do your preventative screening, and you therefore have a condition that's chronic and becomes exacerbated and is now a disparity. So I really say it's all of our parts. We all have a part to play, but you can't just say that without empowering people.
Exactly. So I really appreciate that. So you're starting at the individual level, like, so each of us has a responsibility to advocate for ourselves in our own health arena, and maybe for those that we care for, like our parents or our children. And so you also mentioned policy literacy. So how, as an individual, do I show up at a healthcare facility and need to use policy in order to advocate for my own health? Give me an example of that.
Well, a great example, and it's timely, correct? Let's talk about the monkeypox vaccination. Okay. And about how those vaccinations, the doses, I'm having flashbacks to COVID, when vaccines were trying to put together distribution plans, right? Like, who is most at risk? And if you're not following this initiative, and if you don't understand that there is a dosing scenario about what agencies, FQHCs, the Indian health centers, the larger private healthcare entities, these vaccinations are being distributed in a sequence and in an order. And in order to know when it's an opportunity for you to be able to have that doses for your own protection, it behooves you to understand that scenario. Mm-hmm. So that's kind of a working example and a current example that's going on right now.
Okay. And so where would I find that information? So use FQHC, so federally qualified health centers. So, but what is that all? How do I find that information? Is it a Google search?
I actually have an amazing flyer. If I could maybe share it with you, that sure. Does consolidate. I just had my annual advisory committee meeting yesterday. So I've got a flyer in both English and Spanish. Okay. And I'm not tech savvy, so I can't share it right now. I don't want to get disconnected, but I can share it with you following this, and maybe you can e-blast it out to your listening audience.
Yes.
But it does contain information about access and also about awareness building, transmission rates, and methodologies.
Mm-hmm.
And what I'm working with going into next week is making sure that future iterations of information is going to be very, very culturally relevant and sensitive, because I'm sure, Dr. TR, you know, this is something that's going on with the monkeypox situation. We're sometimes focused on the current population that's most at risk and not looking at transmission rates and procedures and methodologies. And that tends to be a very divisive way to go about this. It takes us back to the HIV response and how this disease is not going to stay in one population. And it behooves us to prepare everyone. So if it's okay with you, Kenadie, I will share that flyer with you at the end of our talk today.
Mm-hmm. Yeah, absolutely. Would love that. Dr. TR, what do you think, who's most responsible to hold our society accountable for disparities in general and particularly health disparities?
Like Tina said, I think it's on all of us. As an academic, though, I come at this from the education side, and it doesn't just start when students get to my level in terms of graduate education, but it starts early on in that pre-K and that K through 12 education, because we know that if people have more knowledge, then they oftentimes will make healthier decisions, number one. If they have at least a high school diploma, they will make more money than somebody who doesn't have a high school diploma. And if they have a college education and so on and so forth, their income levels get important. Why is that important? Because one, in this country, our insurance, health insurance, is tied to our employment. And so being able to have a job that offers these services is now an important thing in terms of health disparities. And that's part of what made Obamacare, important for everybody, was being able to say that everybody has access to a minimal type of insurance, health insurance, was very important. So that's one angle of the education piece. But the other angle of the education piece too is, because I'm involved in educating people who are going to be moving out into the workforce, it's my responsibility to be able to educate them on how to work with communities of color and all populations who are at risk, and making sure that as much as I can support students of color who are coming into the system in higher ed, to be able to make sure that they're finishing their degrees and being able to move on into other jobs. And so that we're forming this pipeline of producing not only just students, but in particular students of color, so that people who are from communities of color, other underserved communities, other disenfranchised communities, have that representation amongst people who look like them. Mm-hmm. And who are providing them with services. So it is not, as historically has been, where medical practice and medical symptoms and treatment is based on white men. It's now being based on everybody. And we have to get to that point in order to be able to start to understand issues from other perspectives, and therefore result in health disparities.
Yeah, that's really good. Certainly working on behalf of nonprofit organizations and helping them to also increase minorities in workforce development. Healthcare is an awesome opportunity that you don't need a college degree in order to get into, and particularly when it comes to certified nursing assistants working with NB Hope, and medical assistants working with NB Careers, and all of the hospitals really in our valley. We are really helping to increase those people who do the most care, right? So you see the doctor twice a day, just checking in the morning, checking in the evening. But it's that CNA, who provides a lot of that care for you, and seeing people who look like you and know also how to treat you, even if they don't look like you, is really important. Tina?
And Kenadie, I just wanted to just add to that and echo to that. There's even an earlier opportunity, a more grassroots opportunity to have individuals embark upon the healthcare profession and responsibility, and that's a community health worker. Those individuals are, by definition, from the community in which they live, and they're the person who can be maybe your first line at a preventative healthcare screening. And they're so important because also, Dr. TR, you can probably give more information on this than I can, that they're able to then be a conduit for information. Like when there's a monkeypox scenario, they can bring this up. And there's also the cousin to the health community health worker. There's even comparable scenarios in Hispanic speaking communities. So these two categories of individuals coming through the community level and serving at that pipeline, they can also, though, if they have the aspiration, then step into higher levels of care, like you were describing, Kenadie.
Right.
But I think it's that network that's so important, because individuals who may have had experiences with medical racism and be very leery about engaging in a more traditional way, that's the first time, and maybe they're going to establish a baseline of their vitals through that community health worker. So I love that you brought up the workforce pipeline and how we can diversify it. And I just think that a CHW is a great way to start.
I agree.
So, and let me just add to that, yes, we're talking about this from a healthcare perspective, but businesses who, like Tesla, for example, who aren't doing, healthcare related work, need a healthy workforce. And so in order to have a healthy workforce, they've got to be paying people at a level that they can be healthy. They have to be providing them with adequate insurance and things like that, as well as paid time off if a person needs to take time off from work. So this isn't just about, oh, well, this is only a healthcare issue. And, I work in, this business, I lay pavement, this doesn't have anything to do with me. It has everything to do with you if you can't get healthy workers, or if your workforce is getting sick and can't come back as a healthy worker. So this has everything to do with that. And even to the point too, you're talking about like families. If one person is sick in the family, that impacts the entire family in terms of people being able to work and who's available to do things and so on and so forth. So it's not just, while we talk about health disparities as a health related issue, it's really something, again, when we're talking about the whole community, businesses have to understand, how does this impact who I'm working with, who I'm working for, who's buying my products, because of now the health issues that they may or may not be facing.
I love that, Dr. TR. I think the better we can get people focused on the full definition of health, the better. And as I said earlier, it's a state of complete physical, mental, social well-being, correct? It's about a community's wellness, because we are only as strong as our weakest link, correct? And if there's a subpopulation within our community and they are, there's a hot pocket for diabetes in a certain zip code, we need to pay attention to those vulnerabilities and address them where we can and with all the resources we can, be it from a health providing entity specifically or not. I thank you for saying that, Dr. TR.
Yeah, and continue to expand it for business as well, because we were talking about what responsibility people have. And you kind of said something that struck a chord with me, because in early 2021, in January, my husband had gotten COVID. So this was before the vaccinations, and when people, the death rate was still very high. And his admittance into the hospital, I didn't know, right, what was going to happen. And the stress of that caused me to have a panic attack, and I went in the hospital, not because of COVID, but just being stressed. And I have 2 little girls, and at the time, a company who was still trying trying to get outcomes from me. And it was great that that there were other people around me who could sort of say, hey, I got you. But without that, without a company understanding that while I wasn't coming down with COVID, just the stress of trying to deal with a person who has COVID in my house, and two small children who still need to get back and forth to school or not, or online or on Zoom. It was a mess. And not having enough people, to really prevent that stress from happening was scary.
And Kenadie, I'm so sorry. I'm having a recollection of that, and I just want to say that I'm so sorry that you experienced that. There's nothing behind that but a period. But what I will say is that, to your point about companies being able to recognize that a workforce needs more than just the traditional modicums of care. For example, an employee assistance program. And if you can't have a full-fledged employee assistance program, I know what we're doing as a result of the proclamation against systemic racism, we had for about a year now have been conducting a BIPOC support group. And it serves an aspirational purpose, but it also allows us to hear themes. People are in that group in a safe psychological space to talk about engaging as an employee of the Department of Health and Human Services, and what does that look like, and how does that feel, and are you supported as a person of color? But we also are listening for themes that we can then maybe address from an HR perspective, or some of the other legacy systems that make up a governmental operation. But again, to your point, companies, and Dr. Tiara's point, companies have to think more than just keeping people showing up every day from 8 to 5 and crank. You want longevity and resiliency, and that takes more than just being, well, they get a paycheck and they should come back tomorrow. So yeah, I'm sorry to have to hear that again, and hopefully our companies and our corporate partners will take heed to that.
Absolutely. Dr. Tiara, I think you're about to say something.
Oh, no, there's a lot of things going through my mind, but it's just, some of this just can't be stressed enough, that with the great resignation, we're seeing that, people are leaving the workforce because of issues that they were having, and they were like, they could no longer do it. I was just reading something about even silent quitting, where people are doing the bare minimum, and they're like, I'm not doing any more than, this is what my job description is, and that's all I'm doing. I'm not putting any effort in. And so, companies really have got to step back and say, okay, how do we do this better? I'm from the Midwest too, and my dad worked in the GM plants, and I remember him talking about them taking, fellow employees out on a stretcher, and it almost happened to him, but it didn't happen to him. And thinking about, like, how do we make things more palatable to people? How do we address some of these issues of power and control, because of the impacts that these have on health disparities?
Yeah, it reminds me of Stephen Covey. One of the key things that he talks about is, if you're the goose laying those golden eggs, right, for your company producing the greatest outcomes, if the goose is sick, there's no golden egg for you to get, right? And so, in protection of profit and outcomes and progress, health really is a central focus of that. Dr. Tiara, I promoted right before this, before our time together, The Color of Care, which is a documentary that people can get on Roku, about really the COVID healthcare crisis and what was happening, and how people of color were particularly pushed aside when it came to emergency. You're not really that sick. And when they went back to ask the hospitals about certain individuals, most of them responded with their public statement of, we provide healthcare for, or high quality healthcare for all patients. And we know that not to be true. It's just, that's what the disparities are about. And even if they are not intentional, it still is happening. And so my question to you is, are you working on or suggesting to companies or hospitals specifically any ways that we can provide solutions to some of the healthcare disparities that are happening, particularly in hospitals or in our healthcare facilities?
So, so first of all, let me just address some of these statements that people are making. When George Floyd passed away, there was a lot of statements being written, oh, we support our Black and African American employees, our employees of color. And the reality is in quite a few organizations that wasn't really the truth. So really what was happening is those statements were gaslighting Black and other employees of color. So first of all, let's just acknowledge that, and the impact that has. Like, as an employee, as a Black employee, you could be sitting there like, wow, you said you were supporting your Black employees, but nothing's changed. Everything's the same. So, we've got to think about that and how we are using statements. If we're not, statements sound good, but they're only as good as the paper that they're written on. So if we're not doing anything to address the situation, then the statements are really kind of meaningless and probably should stop, because again, that's contributing to the stress that people are experiencing.
Mm-hmm.
So that's first and foremost. But then in terms of solutions, so as you and I had discussed, when I was this past year on sabbatical, I was been working on this document about anti-racism in clinical settings. And so like one of the things that came out of my literature search that really kind of stood out to me was this whole use of electronic health records and electronic medical records. And not from the perspective of, oh, we're just putting in all this information, but healthcare organizations on, say, a quarterly or a semi-annual or an annual basis is going back in the system and saying, if our standard of care is that a person who's diagnosed with diabetes gets a referral for diet education, and they get a referral for physical activity education, and they get a referral for, who knows what else. They're prescribed certain medications, and they have a prescribed time for coming back for follow-up. It's then going back and looking in your electronic records and seeing, is that standard of care being followed and by all of our providers? And are there certain populations where this is not happening? And figuring out from there what's going on. Why is it that, for example, our Native American population is coming in and they're not getting these things? They're not showing up in their record, even though this is our standard of care and this says what we're going to do. And then you step back and you say, okay, as a system, we need to talk to our providers and remind them, hey, this is what you're supposed to be doing. This is, the standard of care that we are expecting you to provide, so that it really gets people to think about, okay, here's what we're supposed to be doing. Here's what we should be doing. And here's, and so then it gives everybody who's coming through an opportunity at being able to be healthy, because now everybody will start to get that same quality of care. So that's like just one of the, things that stood out as something, like, yes, we always talk about, organizations should do a self-study and an assessment. There should be training, but taking things a step further, like I said, that was one that really stood out. Like, here's really a definitive way where people can say, oh, this is what we said we were going to do. This is what we're doing. We're not doing it. So now let's go back and have a conversation. Let's bring everybody up to speed and make sure. And then from there, obviously, you can then, if you can start to show that there's this pattern, then you can start to say to your providers, hey, look, you've got to do better, or there's going to have to be some consequences for not following the standard of care. It's not that you're treating people, we're not focused on you're treating people different. We're saying you're not following the standard of care. And so that's one that really stood out.
Kenadie, may I add another layer to that amazing example that you just laid out, Dr. Thompson-Robinson, and that's the economic perspective. Especially, we're talking about, I think you asked the question specifically about private care entities and hospitals. I think that's what you said, Kenadie. But for them, and specifically for our managed care organizations, MCOs, there's an economic piece to it. And if they are thinking about it from the perspective of chronic disease management, that's the most expensive thing, correct? If somebody has a disease that is just never going to go away, we haven't resolved it yet, it needs to be managed. That is a huge drain, especially because it is disproportionately affecting persons of color on the Medicaid system. We see that. And if you really are interested, as to Dr. Chiara's point, in addressing persons of color and the needs that you already know are disproportionately affecting them, that is a motivation, an economic motivation. It is a huge cost to them to continue to address chronic diseases, especially if they can do so in a more responsive way.
Definitely. And I used to work with Pfizer, and it was upsetting because in the healthcare facilities in the hood, for treating with Provocol, treating high cholesterol in the early 2000s, that was not as efficacious as what was out at the time, which is Lipitor. But Provocol is the only thing those managed care organizations were paying for. But it would only reduce, your cholesterol by 40%, whereas Lipitor at the time was reducing it, by 80 to 90%. And it just didn't make sense that they would not pay for the best available drugs, on the market, but lower income people, they would not pay for the most efficacious drugs. And so
that sounds like another panel to have for your next podcast, because that is a very, very deep question. Deep.
Absolutely. And so, but my brother currently is working, he trains doctors and hospitals and facilities on electronic medical records. And I think that what you proposed, Dr. Chiara, is the only thing that I've heard that sort of fights data with data. So, this is what's happening. You put a statement up, but nothing changes. But show me that things are changing. Show me at least that your doctors are offering patients what they offer other patients. Right. In that core of care, they talk about, they don't offer the high, the most efficacious medicines. They don't talk about, certain treatment protocols. Is it because, they don't think people will understand it? It just doesn't occur to you because you're talking to a brown person, or you just don't say it because you have to get to other patients and you just, kind of in and out. And so looking at just at base standard of care, I think is a great place to start. And I would love to be updated, if you're able to see different entities take on that recommendation and what happens and, what they're able to find. So thank you for the work that you're doing on that level. And so I was going to ask if personally, have either of you experienced any disparities in healthcare yourself? And what were you able to do about it? How did you handle it?
Yes. I think it, we all do. I also, I have 3 kids. I'm a single mom. So sometimes showing up in doctor's offices, urgent cares, emergency room, in jeans, tennis shoes, and a t-shirt with a baseball cap on my head, I don't look like Dr. TR, although I'm not quite sure what Dr. TR should look like because it's still me. And so, I even remember early on, this was before I was even a professor, taking my son in. He had severe cases of ear infections, like it was like chronic ear infection. And so, take him to daycare, the single mom thing, please let him make it a few hours so I can work and get paid for a couple of hours. And, getting called, hey, you have to come get him. He's running a fever. Take him to urgent care. Urgent care is like, yeah, we think you might have meningitis. You need to take him over to the hospital. It just so happened the doctor that I saw in the ER was one that he had seen another time. And she's like looking at me like, well, what do you think? Do you think he has meningitis? I said, well, wait a minute. Time out. I am not a doctor. That is you. That is your job. You're here to diagnose. I'm here as his mother because that I've been referred to you for that. I said, he's, 6 months old, 8 months old, whatever. I'm like, and he's growing every day. I said, so, and he's had a chronic ear infection. So I can't tell you what's natural and what he should be doing and what this looks like. And, and I just exploded on her, because of the stress of everything. And she stepped back and she said, you know what? She said, you're right. She's like, I need to do my job. And so she did finally say, yeah, I don't think he has meningitis. And I think she might have ran some test or something like that. But I mean, this was a 21-year-old mom who was saying, I need you guys to do better. And fortunately, she was willing to listen. Okay. Because the other part of it is, the other side is, I'm often told that I can be intimidating to people because I'm 5'7", because, I have a slightly bigger build, because I come from a family that has very deep and loud voices. And so, I'm always mindful of that. And so sometimes I don't speak up. I don't say, because I'm like, I just don't have the energy, but then, in COVID, I, go to urgent care because I'm having an allergic reaction. And the person was like, no, you need to have it. The doctor's like, you need to have a COVID test. I said, I get that, but I'm telling you, I'm having an allergic reaction. I am allergic to mold. I just ate something I shouldn't have. Yes, I'm struggling to breathe, but I'm having an allergic reaction. And I think she actually went out of the room to talk to somebody who said she's probably having an allergic reaction. And, so then she came in and treated me for that, still did a COVID test. For the record, I never got the results back of the COVID test. So I think she did it and never put it in for processing. Mm-hmm. So, this does happen, and it doesn't matter, title, insurance status, things like that. People still, when I come into a facility, they see a Black woman. They don't see a tenured full professor in public health.
Right. And we know that, at least when you're Black, that doesn't matter. You can be a $1 million basketball player. If they don't know who you are, they're asking you the same questions they'll ask, another kid.
But even if you do, look at what happened with Serena Williams. Look at what happened with Allison Felix. These are high-profile women, Olympians, who are making, Serena will retire as one of the highest earning women tennis players. And, she's still having to go through this. I read an article recently about a Black woman who turned out she was having pulmonary embolisms, but a nurse is telling her, oh, you're just having a panic attack. You need to calm down. read another story about a Black woman who was doing like this. And the nurse, the white nurse said, I think she needs a psychological consult because she keeps doing this to her head every time I come in. And
when
the
we
Black
know what
nurse,
that means, when we know
right,
what that
she
means.
didn't, right, she didn't know what that means, you know. And so the Black female nurse went in and said, oh, she has a weave. Like, there's nothing wrong with her. But had there not have been a Black nurse there who could verify that, and even at that, that still created conflict between colleagues. You know, I mean, we laugh, but these are
It's
the
not
things
funny.
that
It's funny, not
people are
funny. I'm not
dealing with. Yeah, these are the issues that people are dealing with day in and day out. Not only just in healthcare, but I could see me sitting in the office doing like this, and everybody's like, well, what the heck is wrong with her? Why does she have her pen and digging in her head like this? You know? And not understanding who, what, how, when, or where, and saying, oh, well, something's wrong with her, you know? Or, you know, the angry Black woman syndrome. Oh, she's angry, you know, because she's loud and she's demonstrative. Well, you know what? She's been trying to tell you forever that there's an issue. You don't want to listen to her. You know, Bob told you, Bob repeated exactly what she said. You still didn't want to listen to that. And now, yes, she's tired.
Yep.
She's justifiably angry. She's not an angry Black woman. She's just angry.
My goodness. I think that that is another conversation we could have in another hour-long setting. That is amazing. My example is actually back to the workforce example. It relates back to that. So I think that Dr. TR, you gave a very good example from the healthcare perspective. I have an invisible disease. I have multiple sclerosis, and it's an active case of multiple sclerosis, but my symptoms all happen to be invisible. So that's an entirely different set of culturally sensitive tools that people need to be cognizant of, that every disability is not visible. And we train on that when it comes to class standards, right, Dr. TR, that every disability is not visible. I'm not going to say how long I've had this active symptoms because I'm going to talk about a previous employer and I don't want people doing the math. But a supervisor of mine, Kenadie, was very much aware. I went on record and did my family medical leave paperwork in case I had a flare and needed to take time off. You know, I did all the necessary preliminary paperwork and had been very open about what my symptoms were and could sometimes how they manifest. So this person was very aware, had even gone so far. I think there was one day I'd come back to the office and I was talking about a lot of my symptoms are in my hands. And I said, you know, I'm just really struggling right now today. And my doctor gave me this topical medication, but the nerve pain is still really flaring up. And they even asked me, did you get samples of the medication? You know, maybe I could try it. I've got some nerve pain. So that wasn't the problem. The problem was this person being so aware of my circumstance. And I never really requested accommodations. I just wanted people to be aware that if I appeared odd, like sometimes it's difficult for me to hold utensils, and I'm hypersensitive about that. I'm the person at the dinner table and like my fork might fly across the table, you know, things like that. And so I started getting poor performance reviews based on things, and the things were like, you know, you're underperforming in the amount of productivity per day. You know, we noticed that, for example, I can produce 50 emails a day and you only produce 35 and things like that. And it just got to the point where it was such a nitpicking of and a professional level. I'm like, is this really is this the success standard? How many emails I produce? You know, the work that I'm doing, I don't think that's a success standard. So I literally had to make a decision about filing claims and going through litigation, which is a stressful scenario and not good for me either. And I just had to leave the employment opportunity and go somewhere else. And I say that to say that, you know, that was a hardship for me to bear. It could have derailed this particular, you know, performance track that I wanted to pursue further. And I just took it upon myself to just leave that scenario. But the takeaway from this is that, you know, we have issues, as Dr. TR described, within healthcare facilities and with dealing with clinicians. But back to our employment base and our corporate partners, be mindful and be sensitive that when you're trying to be culturally aware and giving accommodations, that not all disabilities are visible.
Thank you for being so transparent, Tina. I really appreciate that. And again, back to how employers, really can support their high performing employees so that they can do more. I also appreciate your story too, as well as walking into an urgent care and getting what you need. I'll end today with, it's been a family show. I've been talking about my brother who is in Keith Cobbin, who's in electronic medical records. But this one I'm going to do on behalf of our aging population and our elderly. My mom is a very great advocate of her own health, and she was recently prescribed medication that was contraindicated for her based on her age, her weight, and even some of her symptoms. And so the key to that is she reads. My daughter just got a medication that was happened to be next to me, but it's that package insert. That package insert tells you everything you need to know about a medication. Don't just throw it out when you are picking up medication, but read it. It's usually not that long. It's front and back. But usually look at where there are contraindications for other disease states you may have, pregnancy, and the adverse reactions that you can have based on taking this medication. And so contraindications, she goes back to the doctor and says, listen, should be prescribed for anyone over 5. I'm over that. It should be prescribed for someone who is taking a daily aspirin. I'm taking that, and so on and so forth. And there were several times the doctor had to re-prescribe something that was more appropriate. And quite honestly, sometimes some of the medications would be life-threatening had she taken the medication. And so I am saying for sure, I agree with what we talked about earlier. Please be an advocate for your own health. Also help hold your companies accountable for taking care of you and your family. They're not just there. They're not just a paycheck. They are losing your job has critical consequences for you and your family. And so they have to realize how important they are in your entire ecosystem of care, as well as, look to your government resources, who are there to support you, and academically look at that research and data so that you know when you're at risk and how to sort of mitigate those consequences. So yes, we all are responsible. And I thank you for the work that you're doing, Tina, from the government level, and the work that you're doing, Dr. TR, from the academic level, and the opportunity to talk with you all today. And so good luck, keep doing your work, and to everyone listening, keep being a strong advocate for your own health. We did talk about earlier that today I will award 3 Amazon gift cards to engage listeners. There are a few of you who did some comments that are LinkedIn user. I'm not sure if you're able to, if that is how you came up on screen. I would love it if you also would put in your name or send me a private note letting me know how to contact you via email so that I can send your Amazon gift cards via email. Thanks again for all that you do. Great talking to you ladies, and I'll talk to you soon.